Now invite Sudhir Vaishnav, who will speak on PCI versus CABG, who wins in India. Sudhir Vaishnav.
Hi, at the outset, let me thank Srinivas Kumar for getting me here. And I am following Jimmy's talk, PCI versus bypass surgery, who wins in India. Probably we are talking of multi-vessel disease, we are not talking of single vessel disease, and we are also talking of unstable patients, not stable patients who Dr. Jimmy Dalal spoke about. You know, the surgeons were caught napping. Angioplasty had tremendous advances, and today the indications for angioplasty are left main stem protected, unprotected, multivessels, long lesions, calcific lesions, total occlusions. All this is possible because of new devices like DES, ROTA, cutting balloon, glycoprotein 2B3 inhibitors, IVUS, and newer antiplatelets. About angioplasty versus bypass surgery, what does the earlier data tell us? Barry was the first trial which raised some concern for us in terms of diabetics undergoing angioplasty. But if you look at the Barry registry, that showed that if you treat your patients prudently, when they are treated outside of randomization, the patients of diabetes also do equally well. So that was a bit of an encouraging sign also. However, all the various trials which were done earlier showed that PTCI had less number of asymptomatic patients as compared to bypass surgery. Target vessel revascularization in angioplasty was 3 to 10-fold higher, and 20% of the PTCI group required CABG at 1 to 3 years. This is earlier data when stents were not used. What happened when stents came in? The RISE registry was the first time a registry which showed that in patients with multivessel disease, stenting resulted in lower need for repeat revascularization than previously reported by various angioplasty trials. ARCH trial was a randomized trial in the bare metal stent area, and when you exclude revascularization, bypass surgery and angioplasty continued to have the same results, which was not statistically significant. If you look at this slide, which showed that the results of bypass surgery were fairly standardized, but when stents came in, angioplasty as compared to plain old balloon angioplasty, stents were a great improvement for us. What happened when stentomania came with diabetes, the DES success in diabetic patients? ARCH 1 trial, if you look at it, angioplasty with stent in a diabetic patient with bare metal stents, the patients did not do as well as angioplasty with stent in non-diabetics. The reason was simple, that if you have occlusive restenosis in a vessel, then these patients will do poorly. But if your patients do not have restenosis, or if they have partially occlusive restenosis, these patients will do very well. And the first trial was done with the Endeavor trial in diabetic patients. It showed that you had a significant reduction in target vessel revascularization. ARCH 2 was a registry trial which was done subsequently, which showed that the total MACE between angioplasty and bypass surgery had come down significantly when you started using DES. There was sobering of enthusiasm with late stent thrombosis, as we all know about. For every 100 patients who were implanted with DES, 5 repeat target revascularizations at 6 months are avoided, but at the cost of 3 late cardiac deaths or non-fatal MI. This led to the famous outburst that we know about from Salim Yusuf, but needless to say that today with the second generation and the third generation of drug-eluting stent, this concern of late stent thrombosis to some extent has been resolved. Now, when you compare angioplasty with bypass surgery, it is really like comparing apples to oranges. A patient with distal left main trifurcation lesion in combination with an occluded right coronary artery is pooled together with a patient with 3 focal lesions in the mid portions of 3 coronary arteries. Both are reported as 3 vessel disease, but both have completely different prognosis as we know. The absence of grading of the severity of coronary artery disease and the lack of comparison of lesion complexity based on pre-treatment angiographic criteria between various groups was severely limiting the interpretation of these earlier trials. My video is not playing from here. Yeah. Now, if you see this patient, he has got a critical left main stenosis.
Click again.
And he also, and he also had critical stenosis of the mid LAD with involvement of the diagonal. He underwent an angioplasty with 2 stents. Now, the question is, you would ask me why? Well, A, the patient was not willing for bypass surgery. 2, he could afford 2 medicated stent with the use of IVUS. And 3, his syntax score was 24. So what is this syntax score? There was a large trial which compared angioplasty with bypass surgery, and patients were divided based on the syntax score into patients who had low syntax score, intermediate score, and high score. And in a separate analysis, a syntax score cutoff of 34 was found to be the most effective in distinguishing patients at high risk of mortality from cardiac causes after PCI. The 5 years data of syntax trial are out. Yellow continues to be the angioplasty. If you look at 5 years out, death, cardiovascular, cerebrovascular accident, and MI still continue to be slightly higher in the angioplasty arm. CVA, however, fortunately for angioplasty, continues to be lower than bypass surgery. If you look at in the low risk group, there is not much statistical difference when you do angioplasty versus bypass surgery, even in the left main setting. But as the syntax score keeps on going up and more than 33, there is a huge difference that you see in terms of outcomes on your patients. So yes, I will definitely do angioplasty with the present generation of drug-eluting stents. However, now after the syntax trial, probably we will do the syntax score, and if the score is less than 33, then only probably offer angioplasty. If you look at the MASS trial, which was a large trial, 10-year data from United States, which compared angioplasty, medical therapy, and bypass surgery over a 10-year period in patients who were stable. For all groups of patients, unfortunately, the patients did well with bypass surgery in the MASS trial also. However, if you look on this slide, medical therapy was the worst amongst all, with angioplasty being in between. And the latest trial, which we talked about all the way now everywhere around the world, is that is this the end of angioplasty in diabetics? Is the FREEDOM trial. And if you look at the FREEDOM trial, the red line, which is the angioplasty line, unfortunately does not do as well for death, stroke, MI as compared to bypass surgery. So also myocardial infarction, so also all-cause mortality, so also repeat revascularization. Stroke, fortunately for us, is the only saver where angioplasty compares better as compared to bypass surgery over long term. And in the FREEDOM trial, there was no difference based on the syntax score, whether it was low score, whether it was intermediate score, or whether it was high score. Patients continued to do the same did better with bypass surgery as compared to angioplasty. And the conclusion of Freedom trial by Valentine Fuster was CABG was of significant benefit as compared to angioplasty. There was no significant interaction of the syntax score or any other pre-specified subgroup, and CABG is the preferred method of treatment according to Dr. Valentine Fuster. So why does bypass surgery continue to do well in diabetic patients? There is very diffuse atherosclerosis with high risk of plaque rupture and progression of disease at non-stenotic segment. More complete revascularization by CABG likely to be important as disease progresses. CABG, particularly with arterial conduit, protects the proximal 6 to 8 centimeters from MI due to plaque rupture. So now what is the scenario in India then? If you look at the data presented in the National PTCA Registry for the year 2012, angioplasty is continuing to grow in India. It is growing now at the rate of almost 17%. If you see, drug-eluting stents are used in a high proportion of patients, but that is plateauing out over the last 1 year. So coronary interventions are increasing each year. There is a trend for smaller centers coming up across India, and medium volume centers are moving upwards. Around 45% of the procedures are performed by large volume centers. The percentage of interventions in old and younger age group has increased. Radial approach has had a significant upwards trend in the last year. Percentage of drug-eluting stents has plateaued in the last year. Percentage of acute MI interventions has marginally increased. Glycoprotein 2B3 inhibitor use has decreased significantly. Use of IVUS and FFR has increased. All complex procedures have increased. And needless to say, complications rates have gone up because probably more challenging cases are being done. If you look at this, angioplasty centers, 390, 200,000 plus cases, surgery being done in 161 centers, 80,000 cases, out of which about 40,000 are bypass surgery. So to conclude, no patient cares about his acute gain, no patient cares about his late loss, no patient cares about his binary restenosis rate. The patient only cares if he dies, has a MI, needs a repeat revascularization procedure, or has recurrent angina. I am an optimist, and I feel with the second, third, and the fourth generation bioabsorbable stents, some of the limitations of angioplasty will be taken care of, and also with the use of newer antiplatelets, which are now routinely used, stent thrombosis will probably vanish. However, no trial so far, including the Freedom trial, which was the latest trial, has looked at the second, third generation of stent with newer antiplatelet. And also with the stent prices moving southwards at a rapid pace, angioplasty with multivessel stenting will become as affordable as bypass surgery. So I leave it to you all to decide who is the winner for now and in the future. But in my mind, it is certainly the patient. Thank you all for a patient hearing.